And this is AV synchrony of the VDD leadless pacemaker. We all know that we have to plant many pacemaker, and there's more and more leadless pacemaker will implant in our countries, and some patients need the DDD models. So the micro AVs can provide the VDD pacemaker models. So the micro AV DDD in our country is just the first general pacemaker of the needle pacemaker, and the second general will become soon, but they have the similar mechanisms. So micro AV DDD models share the three axes, center, rheumatic, sense and vector. So they have the three axes, X, Y, Z, and they mark it as the vector 1 and vector 2 and vector 3. There's the detail of these mechanics. The VDD models are not just like the electric grams, but it is sense the contrast, the mechanical. And so the A1 is the tricuspid and myocardial valve closed. And it means the state of the ventricular systolic. And A2 is aortic and pulmonary valve closing is the end of the ventricular systolic. And A3 is A3 is the end of the ventricular diastolic. It means the passive ventricular feelings. If in the echo, it is similar times corresponding to the E waves. So it's very important. It's the atrial mechanicals. And the A4 is the atrial mechanical contrast. It's the positive contrast of the ventricular, our heart. We all know that if the patient have the atrial fibrillation, the atrial contrast will be lost. So we can't find the A wave in the echoes. So it's very important that it marks the time, period of the time. So the ventricular end, it means the all ventricular contrast or the diastolic. So the VE, the end of the ventricular single is from the A1 to A3, so we'll know that it is all for the mechanicals, VDD measures. And there's some markers is AM. AM means the atrial mechanic. So, and there is other mark I will say later. This is the programs of the micro AV. It is overview of the micro AV. So the AV micro AV pacemaker, needle pacemakers have many kinds of the models. But VDD models, we showed adjust the model to VDD. So from the, if you adjust the model to VVI, there's no atrial. They only have the RV. So if we just adjust to the VDD models, there will be atrials. So we make sure that the atrial sense setup It's very important for the VDD models working. So there's many kinds of sensor. It's a sensor future. Sensor futures we should include that A3's threshold and A3's window and its means periods, and A4 threshold. And the pace features is readers most attract auto PVR RP. So, and we can check these features of these screens. The default of the micro AV setup, the VDD, the data rate is 15 PMB. We all know, we should know that if after the pacemaker implanted patients, the monitor will be showed only 15 PMP. Someone will say that it doesn't work because our the pacemaker's data rate is 16, so we all should know that. And there will be end of the VE just already said that, and it means the A3 and AM means the atrial mechanical contrast. So this sensor features atrial sense. We can show here. We can connect this, and this window will appear. There will be rhythm smooth track checking to auto PVRT, and there's another function is model switch. The model switch includes two switches. It's active model switch, and another is AV conduction model switch. It can be turned on or off. And after that, we can say that it is pacing features. We have the VDD have the rate smooth algorithms. It is shows that if it's AM and it's okay, if it is appropriate atrial mechanical sense with synchro ventricular pacings. But here we can see that it is the atrial under sense. It is means we can't see the atrial contrast. So VP occurred within the rate motion interval. If there is no VP within the rate motion, it will be a lower rate. So, and then it is checked, and the atrial ventricular synchron recovered it VE, and it is AM. VE is end of the ventricular, VP is ventricular pacings. And it's another function is tracking check algorithms. It is one is normal, and the two we can say that after immediate ventricular rate, check rate, the tracker check extend post ventricular atrial traffic appearance within the follow AM mode. So it will prolong this appearance. And after that, there is AM, so it is returned to back. It will be save some problem. And it's another function is the model switch. A model switch is not just like the general pacemaker. Its model switch is VDD, and if the conductions, AV conductions is okay, and more than heart rate more than 40, the AV contractor model switch VVR is turned to VVR. If it is conductor, it can be transfer back to the VDD if the AV block happened. And another function is activate model switch, but it must be support rate response supposed that it is about the external romantic detect high activity. We all use somebody's work high activity, and the ventricular rate is low, so there will be changes the VDD to the activity model VDR, yes. And another happened if the a low rate tension due to the loss of the H track, it will be switch to the active model switch VDDIR. This is my patients a long time ago, about 3 years ago. It repeated disease for 1 year and had a syncope. It is EKG, and his echo is normal, and just the only minor regurgitations. And we plant the micro AV, this the tempered pacing lead. And after implementation with just the automatic programs, so the AV conductor models switch is off. So there is VDD is AMVP is 48% about that. You can say this model switch is off mostly, and just after the in the implementation and just after the implementation, the model switch always off. If it's off, there will be AV conductions. And we want more AV conduction pacing, so we use the manual HA mechanism. So we optimize the programs about the A3, A4, and so the data on the first data, the AMVP is about 80%, and after that, his heart rate is raised, so the AMVP a little bit decreased, but more than 17%. And but the patient said want to reduce the battery use. He wants longevity of the batteries and required intrinsic conductor. So we turn the AV conduction model switch on, and you can say that the AMVP decreased only 4%, and the patient feel discomfortable after a few days after the model switch is on. And so we check the patient, we turn the AV conduction model switch off, and the 5th month after operation, the AMVP is more than 17%. After that, after 1 year and after 3 years, his model switch, his APVP is more than 17 or 18. And so it is similar with other report in the journals. There is some cases can just published long time ago. But the time is limited. I have no time to explain how to adjust the parameters. But I will mention that there is very important papers. Is published by Synchrony and compared its meta-analysis compared the VI pacemaker with the VDD pacemaker measures AV OT VTI, but it's no significant difference. And last, I will be recommend the articles and the strategy to improve the atrial synchrony in patients with micro AV lead pacemaker published in Europe Patient 2024. This is patient. This is a doctor from the Europeans, and they recommend the experimentals programs. Recommend this is on many experimental in details about A3. The window or A3 threshold and other things very useful, I think. And there is a flow chart of the patient with every synchronization programs. So that's all. Thank you.